Okay, it's 9 AM UK time. I think we're ready to start this webinar. Could I have the first slide, please? Hello, welcome to this U21 Health Sciences Group webinar on COVID-19 and interprofessional education. I'm Sharon Buckley and I'm the lead for interprofessional education at the University of Birmingham in the UK. And I'm delighted to be here with my colleagues from the U21 IPE Special Interest Group to host this webinar on what is a topic of great importance to us all. Next slide, please. A little about the format of the webinar to start. After this brief introduction, we'll hear a keynote presentation by Professor John Gilbert from the University of British Columbia. And then we'll have a series of short presentations, each around 5 minutes, from panellists from the Universities of Amsterdam, Queensland, Hong Kong, Birmingham and Melbourne, and also from Dr. Emily Audit, who's a junior doctor with a special interest in IPE and who has first-hand experience of caring for patients during the pandemic. All the presentations have been pre-recorded, but I'm delighted to say that apart from Professor Gilbert, for whom it's now around 1 AM in the morning, all our panellists are here with us on the webinar and will be able to take part in a discussion and Q&A session after the presentations. And I'm very grateful to my colleagues on the IPE Special Interest Group, Dr. Alison Mandrusiak from the University of Queensland and Dr. Janet Wong from Hong Kong University for leading on the panel discussion. And we have around 75 minutes for the webinar in total. Next slide, please. A few points of housekeeping. For the best viewing experience, please set your Zooms to speaker view rather than gallery view. And as we're going through the presentations, please submit any questions or issues for the panel discussion using the Zoom Q&A rather than the chat. We will be able to use the chat function, but we will be monitoring the Q&A for questions, and we can't guarantee to be able to pick up items posted in the chat. Questions can be either general for discussion or to a specific panelist, and that does include Professor Gilbert, who, although he cannot be with us, has volunteered to answer questions in writing after the session. So, there's no doubting the extent or impact of the pandemic that we're living through at the moment. As of the 17th of August this year, the World Health Organization had received reports of over 21 million confirmed cases, including 767,000 deaths. And the World Bank forecast a 5.2% contraction in global GDP. Health services across the world are being challenged to a degree unprecedented in modern times, and the effects of the pandemic and the disruption it's causing on all aspects of society will be felt for many years. However, across the world, there are remarkable stories of people adapting to the situation with courage and flexibility and ingenuity, and the picture is definitely not all doom and gloom. So it's really appropriate that we're here today to discuss the impact of the pandemic on our area of interest, IPE, and to share our experience and our adaptations, and to help each other bring something valuable out of the present difficulty. Next slide, please. So I'm delighted to be able to introduce our keynote speaker and our panelists for today. Professor John Gilbert is Emeritus Professor at the University of British Columbia in Canada. I'm sure many of you will know Professor Gilbert, who's been a leader in the field of IPE for many years. He was elected a Fellow of the Canadian Academy of Health Sciences in 2008, was awarded the Queen's Diamond Jubilee Medal in April 2012, and the Order of Canada in July 2011, all for his leadership in the field of interprofessional education. Professor Neil Cottrell is Associate Professor and Director of IPE in the Faculty of Health and Behavioural Sciences at the University of Queensland. His career as a pharmacist, Neil has worked extensively both in the UK and Australia, and his clinical research interests include developing evidence to support the future roles for pharmacists, particularly in primary care. Dr. Fred Ganatais is Senior Lecturer and Programme Coordinator for IPE at Hong Kong University. An educational psychologist by background, his research interests include IPE in higher education and the nature of interprofessional collaboration. Dr. Christine Hirsch is Senior Lecturer in Clinical Pharmacy at the University of Birmingham. She's Deputy Lead for IPE at Birmingham and is committed to evidence-based practice in education, particularly with regard to the role of technology in learning and development. Dr. Rien de Vos is Professor of Medical Education and Training at the University of Amsterdam and has a particular interest in IPE. He's chair of the Department of Education at the Academic Medical Centre in Amsterdam and Managing Director of the Domain of Health in the University of Applied Science in Amsterdam. Dr. Rosemary Mackenzie is Associate Professor in the School of Population and Global Health at the University of Melbourne. She's Director of Learning and Teaching for the school and Deputy Director of its Centre for Health Policy. And her main areas of interest are primary care and public health evaluation and policy. And last but not least, Dr. Emily Audit is a Junior Doctor at the Royal Wolverhampton NHS Trust here in the UK. Following a BSc in Medical Microbiology and Immunology, and completed her medical degree at the University of Birmingham, where she co-founded the university's student IPE society called the Knowledge and Skills Exchange. And she's carried her passion for improving IPE into her now clinical practice. So welcome to you all. I'm delighted that you can all join us, and I'm really looking forward to the presentations and the discussions. Without further ado, I think we can go to the keynote presentation, which will be followed without a break by the panel presentations. Thank you.
Good afternoon from Vancouver, British Columbia. I'd like to acknowledge that I'm talking to you on the ancestral unceded territory of the Musqueam, the Tsleil-Waututh, and the Squamish nations. It's certainly a great pleasure to be with you here today and in this particular format. I'd like to talk about, in this COVID world, the kinds of challenges that I think we're facing with respect to interprofessional education for people-centered collaborative practice and care. I think at this time, one of the obvious opportunities is the ability to reflect on new ways of communicating with students away from classrooms and lecture theaters. Now, of course, we all do this in our very different ways, but when I'm talking about new ways of communicating, I'm thinking about communication for teaching and learning. And then to also reflect on how this disruptive crisis can help us define what interprofessional learning and interprofessional practice should look like. And thirdly, I think it's a wonderful time to reflect on the student generation for whom we are defining that learning, because Generation Z, those students who are coming into the system or are in the system at the present time, are unlike the millennials who have preceded them, because they come with a lifetime of experience and knowledge and activity with all kinds of social media and technology. But I think in reflection, we have an opportunity to refine the role of the educator. So although educators are knowledge holders and we do impart wisdom, it's no longer that which is solely fit for purpose. Because as I said, students are able to access knowledge and even learn a technical skill with just a few clicks on their phones and their tablets and their computers. So we're going to have to move to the role of facilitator in a much bigger way than we have been before. A facilitator of developing interprofessional skills that they can then carry into their professional lives almost without any hesitation. And we all know that at the present time there are problems with moving what has been learned in a classroom with respect to IP to moving it into practice. So I think that the role of facilitator is one that deserves a lot of attention, and maybe this will come out in the panel discussion. What I've been thinking about is that we have to move the learning dial in certain ways, because what has become obvious to us from just doing surveys with our students is that there are two essential skills that are required: resilience, and I don't want to get tied up in all of the definitions of resilience that are out there and discussions of, but we have a sense of what we mean by resilience. Resilience and adaptability, because the ways in which we're presenting information and asking students to learn are in some senses quite different from what they've done before, and they will have to be adaptable. And that requires, on our part, creativity, effective communication. Not to say that our communication wasn't effective, but effective communication in a different medium, in different media. Collaboration of a kind between ourselves, our colleagues, and our practitioner friends. And then empathy, empathy, empathy. This is, as we've all discovered, these are not easy times. And for our students, the load, the emotional load, I think is bigger than they tell us. And of course, it requires, as we turn this learning dial, requires being able to work across demographic and professional lines of difference, many of which I kind of lay at the seat of scopes of practice, which have been very, very specific in many instances about professional activities. So I think we've got to be able to work across those lines and the demographic lines, age, gender, etc. If we really, 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 really want to harness the power that we're aware of, that's called interprofessional collaborative teamwork. And when we're moving that learning dial, we have to ensure that we understand relationship-based care better than we have in the past. And by relationship-based care, I mean the care that we provide to patients, clients, customers, whatever, but also their key role in the learning paradigms that we're now developing. And I think it's important always to bear in mind during this period of emergency remote learning, as we're calling it at our university, that there is this definition, the KP definition, that is really now a global definition for interprofessional education. So when we're developing learning programs, we have to think about learning with, from, and about. We have to think about the purposes of collaboration, and we have to think about improving quality of care and services. How do we do each of these things in order that we are living up to and living in the definition of interprofessional education? And we haven't really got a long way past the first two parts of the definition, although I think we're getting a better idea of what with, from, and about requires. And of course, we have lots of work on collaboration, but I'm not sure it's the collaboration that results from learning with, from, and about. There seems to be different ideas about it. And then improving the quality of services, I think that's way downstream. Until we have the first two parts clear, improving or measuring the improvement in quality of care and services is a very difficult prospect. Two kind of big picture issue, well, two slides in which I'm going to deal with big picture issues. The first is that students know less about technology than we think, even if they are digital natives. And that's become clear to us at my university and probably your universities when they've had to cope with various platforms, whether it's Zoom or Teams or Blue Jeans or whatever's out there. These are supposedly easy platforms to work. But actually, our students sometimes find them quite difficult, particularly when we go into the kind of waiting room era, waiting room time on a Zoom meeting. We have to remember, and it's a big one, that students will be accessing internet on their phones, and they probably have limited data, and they need to reserve that data because it's expensive. Now, we do have university consortia that are trying to work with technology companies to arrange special rates for students at this time. But I think that what we're finding is that the data issue, the access to data issue, is a really big one. So when we're thinking about, how are we going to do interprofessional teamwork learning, then we have to think about how much data is it going to take in order to do that. And really important is that students may be sharing their technology with other household members. In fact, in many instances, they are. And so what that means is they get time on, but they have a lot of time off the system. So in a sense, they have less time to do their academic work in those circumstances because there may be other demands on their time. And then some more big picture issues that are, I think, associated with emergency remote learning. Really worrying is this loss of connectedness between students, which is so much there when they're in a classroom or whether in learning groups or whatever. When they're coming in from different places and at different hours, the sense of connectedness isn't there in the way it is when we have them in classrooms or we have them in tutorial groups or in seminars. And I worry that that connectedness leads to loneliness, and that loneliness can itself lead to mental health issues that we haven't heretofore really had to contend with, and we need to have mechanisms in place to address those issues. It's really important to develop and build co-learning with a patient, a client, customer, by which I mean that here in Canada, we have a wonderful patient voices network, and there's one in each province. And what the Patient Voices Network have been doing have been the standard bearers, the teachers of what it is to be a patient. And they have asked us, can we be part of the learning now, since we don't get hands-on with students? And we would really like to be part of that. So co-learning with a patient client is to be highly recommended, where the patient client understands what their role as a facilitator of learning about their disease body part entity is. I think we have to constantly ask the students for their feedback on the system, because we've learned, and you probably are learning, that students say, well, that really doesn't work. That piece of stuff doesn't work. That thing that you're trying to do with us doesn't work. And so we need to know that so we can make adjustments to the system so that they are much more transparent. And that also engenders the need for structural, flexible approaches to teaching. So the instructions need to be clear about what it is we are expecting, but they also have to be somewhat flexible given what I've said earlier about the data issue. Our expectations have to be in terms of the mechanism we're using to teach those students. Because the expectations when we're doing this stuff online are somewhat different than the expectations when we actually have students in front of us, as I said, in a lecture or a group. And we have to be really, really clear about the objectives of the system. What are the objectives using this particular system as opposed to using small group learning, case-based learning, etc., in a face-to-face situation? We've also heard from our students that we really need to be consistent in a kind of centralized communication approach, that they find it very confusing to get one message from one faculty member, one message from one department, one message from a faculty, when in fact it is possible to ensure that the communication that we're putting out there about the activities we're engaged in, how the university is managing, et cetera, we can do that centrally. And it's a huge, huge issue with students. And I think we really have to think carefully about how we address it. And then using, in connection with this, pertinent and consistent online tools. Again, students will say to us, listen, we can't do 20 different tools. You know, that's not realistic. Like, I'm in 5 courses this term online, and it's unrealistic to expect us to learn. So we have to have consistent online tools which are used across the learning organization into practice, and they have to be pertinent. They have to actually speak to what it is you're trying to do, not just something that would be nice. I would know, not another app. We've also given a lot of thought to scheduling online office hours, regular online office hours. After all, when we're on campus, we do have regular hours for seeing students. We have to be sure that that's in place, they understand those hours, and they feel free to use them. And that's something that only we as instructors can get them to feel comfortable with. Because again, an online office hour is not quite like sitting in your office and talking about some particular issue with respect to a course, or maybe with respect to their mental well-being. And then finally, I think it's very important to avoid drowning students in emails. You know, they don't just get emails from us as teachers in their course, but they get emails from every course that they're in. So it is a good idea to be really solicitous with respect to the emails that we send out. And of course, it also helps us. I mean, who needs another mailbox full of 100,000 different messages? So these big picture issues are ones that I share with you, that I really think are important, at least from my perspective, to grapple with as we deal with this emergency remote learning, online learning, in the days ahead, because we're just beginning, I think. And I think that technology has huge potential. And it's up to us to figure out what that potential is and how to use it to the benefit of our students, of our professions, of our institution, and above all for those people that we're doing this for, which of course is the patient, client, customer, etc. So calling a spade with respect to this is going to be important all the way down the line. We have to be clear that in theory, there is no difference between theory and practice, but in practice there is. So it may be theoretically neat to say, well, we're going to do this, we're going to do that, we're going to do the other thing. But ultimately, you've got to get out there and do it. And we've got to be sure that the theory is not so disjointed from practice that things for the students become incredibly perverse, confused, and drive them away from learning. And that's not a good thing. Thank you for your attention. It's been an honor to be able to talk to you today, and I hope that the rest of the meeting goes well and that there is an opportunity for the discussion to move across some of these issues.
Hello, everybody. My name's Neil Cottrell. I'm the Director for Interprofessional Education in the Faculty of Health and Behavioural Sciences at the University of Queensland in Brisbane, Australia. In this short presentation, I'm going to share with you the impact of COVID-19 on some of our interprofessional education learning activities and how we adapted to these challenges. So for us, the academic year runs from late February to mid-November. So round about late March, early April, Queensland started to ramp up its preparedness for the coming COVID-19 pandemic. That meant for the University of Queensland that there was a pause in teaching activities for a week in about week 4 of semester 1, where all the activities were moved to an online environment. So the big challenge for us was that all of our interprofessional education learning activities could not be delivered in a face-to-face environment. They had to be delivered online. So I'm going to share with you a couple of those where there was quite an impact. On the left of your screen here, we have Southern Queensland Rural Health. This is a facility which is about 130 kilometres west of Brisbane. And there we have a student-led interprofessional education health and wellness clinic with students from exercise physiology, physiotherapy, dietetics and psychology involved in the care of clients as interprofessional collaborative teams. Clearly, due to the COVID restrictions, clients were not able to attend the clinic in a face-to-face manner. On the right of your screen, I have Health 1000, or a picture from Health 1000, Professions, People and Healthcare. This is our foundation interprofessional education program for all our first year undergraduate students. So we have over 1,500 students who are traditionally enrolled working in small face-to-face interdisciplinary tutorial groups. And this program or course was due to run in semester 2. And we had to think about how we change it so we could run it in a COVID restricted environment. So what did we do? So the way we adapted at Southern Queensland Rural Health, the staff there were absolutely fantastic in the way they rapidly transitioned from a traditional face-to-face environment to a telehealth environment. And at the same time, although delivering services to existing clients by telehealth, they maintained the interprofessional collaborative practice approach for our students. So they were still working as collaborative teams. And as you can see on the left here we have a couple of our students checking in on a client to make sure they're keeping up with their exercise treatment and that they're doing it appropriately. For Health 1000, we made the very early decision that we were going to deliver this course online. There were 2 reasons for doing this. One was we were being good corporate citizens. You imagine 1,500 students, the number of small tutorial rooms that we would require. And with the COVID restrictions, that would be more than normal. So we said straight up, we will go to completely online to deliver this course, which freed up a lot of tutorial space. The other thing we did, we have graduate entry master's programs where the students have not enrolled or do not enroll in Health 1000. So we've created some modules that will be embedded in those graduate entry master's programs. And so in a sense, by putting our undergraduate course Health 1000 online, this allowed us to test if in fact we could deliver and still achieve the interprofessional education learning outcomes. So we've trained our facilitators for Health 1000 to facilitate in an online environment, and we're 3rd week into semester, and so far everything's run very successfully. Finally, we have ethics approval for both our clinic and for Health 1000 to do qualitative interviews and surveys of our students to make sure that going into these different environments has not impacted on them achieving the interprofessional education learning outcomes. Thank you.
Greetings from Hong Kong. This is Fred, the Program Coordinator of Interprofessional Education of Faculty of Medicine. the University of Hong Kong. Like many of us, in Hong Kong EU, responded proactively to overcome the challenges of COVID-19 by transitioning the face-to-face IPA program to online, asynchronous, and synchronous design. The HKU hybrid gamified IP model is developed with Learning Activity Management System, or LAMS, Zoom, Kahoot, Mentimeter, and Google Slides as IT platform. We targeted the development of team cohesiveness early on through flipped classroom design, where teams were given pre-class activities. The use of authentic case scenarios informed by case-based and team-based learning principles were important design element. We developed a 10-day online IPE model composed of 9-day asynchronous and 2 hours live synchronous activities. Our online IPE model is composed of 4 parts: preparation, readiness assurance process, application exercise, and enrichment activity, hoping to achieve the IPE competencies, values, ethics, roles and responsibilities, interprofessional communication, and teamwork. The asynchronous part is in response to the differential schedule of students from 5 programs. For day 1 to 3, preparation, consistent to flipped classroom design, students have independent study of the pre-class study materials. They emailed their team members. They also named their team and wrote multiple choice question or MCQs. For days 4 to 5, assurance process, teams discuss the MCQs written by teachers and agree on the answer. On day 5, we disclose the answers for each the teams the chance to appeal. The days 6 to 9, which is application exercise, we disclose an authentic case where the task was to formulate an interprofessional healthcare management plan and answer the MCQs based on the case. And for the final day, enrichment activity is a synchronous activity where teachers went live in one room while teams were at the convenience of their homes. This activity allowed us to process all activities, completed activities, provided feedback, gave out awards, for example, best in team names, best in MCQ writing, best in Kahoot activity. We asked teams to revisit care plans based on the feedback using the breakout meeting function of the Zoom. In both synchronous and asynchronous phase, we feel that the strong IT support was very important in online IPE, where we creatively took advantage of its affordances to achieve the goals of online IPE. All throughout, we used LAMS as e-platform, including Kahoot, Mentimeter, Google Slide. Below are the sample outputs of the teams. We implemented the 4 modules: anticoagulation therapy, multiple drugs, depression, and cancer, involving around 1,000 students from medicine, nursing, pharmacy, and Chinese medicine, and social work. Management plans are important outputs of our design. As shown on the screen, these are the sample team care plans for their professional education module cancer, where they cover various areas of care, including clinical, social, and financial, among others. The color represents actually the 5 programs, and these concept maps indicate the professional collaboration. Our initial data suggests the ability of the model to attain desirable collaborative teamwork skills. Our results in general is very encouraging. Teams valued the application exercise, in particular the case analysis and healthcare management planning. The interaction in this activity is simply noteworthy. The pre-test post-test comparison is also good, suggesting the acceptability of the online IPE. We provided metacognitive triggers, and the feedback is positive, where students valued collaborative care. Suggestions include making the technology more user-friendly. The role of creativity and innovation in integrating technology and IPE are very important. That is our realization. We hope to transition to collaborative practice after interprofessional education. That's all. Thank you so much.
Hello, my name's Christine Hirsch. I'm a senior lecturer in clinical pharmacy at the University of Birmingham, and I'm going to share with you today our interprofessional education event, Teamwork for Patient Experience. The University of Birmingham has an interprofessional healthcare programme including 8 different pre-registration healthcare programmes, which you can see here, totalling around about 1,200 students per year. We have an IPE framework which includes a menu of bespoke activities which may take place between 2 or more professions, but importantly, these support whole cohort activities across 3 main stages of the framework. The first is the introductory phase, raising awareness, and here we provide students with an opportunity to get to know each other during Welcome Week at the start of their programme. The intermediate stage, which is the skills building stage, where students have some experience, for example, usually from placement, and then the advanced stage for students later in their programme, which allows them to apply their clinical skills to practice through simulations and advanced therapeutics workshops. This presentation focuses on the intermediate stage, the skills building stage. Over the past year, we've developed some case scenarios in partnership with members of our Patient, Carer and Public Involvement Group, IPHE. They've called themselves Involving People in Healthcare Education, and they've developed some case scenarios, of which 3 have been chosen. That's the crisis team, involving a patient with Parkinson's and mental health issues. The seizure, which represents the case of a child and their family's experience of interaction with the healthcare team, and a falls patient. The cases were chosen for the pilot, which should have involved a group of volunteer students discussing the cases in a face-to-face workshop to explore each profession's contributions and make recommendations for their management. However, our campus closed at the end of March, and we had to decide whether to go ahead with the pilot, which was intended to be just after the exams in June. After some discussion, we decided to go ahead using our online conferencing platform, Big Blue Button, on Canvas, which is our virtual learning platform. Students were recruited by email and IPE steering group representatives for each of the programmes, and we managed to recruit 46 students who were then allocated into 3 mixed profession groups of around 15 to 16 students. And on the 4th of June, we ran 3 parallel sessions, one around midday and then 2 in parallel. We had one person narrating the PowerPoint presentation, taking the students through this, and then facilitators to monitor the chat and act up just in case the internet connection dropped out and someone had to take over. So at the start of the session, we asked students to volunteer for a role either as a chair of the group, the chat monitor, or as a rapporteur. Students had been sent their allocated case studies in advance by email, but we did allow 10 minutes just to go through the case briefly and make sure they were all clear on what they had to do for the task. We allowed 45 minutes for discussion, with chair and chat monitor making sure that group members were able to contribute to the discussion, other members recording points in the notes in order to review and compile their top 5 recommendations for management of the scenario. Videos of the group discussion and the chat were then uploaded onto the conference section of Canvas, and as a follow-up to activity, students and facilitators were asked to review the recordings and provide constructive feedback on the group's recommendations for the 2 case discussions that they had not taken part in. On evaluation, students commented that they found the online environment actually facilitated communication, particularly with a student monitoring the chat function and using this to bring members into the discussion, something that they felt was easier online than in some of the face-to-face sessions that they'd experienced. The notes section allowed the students to record synchronously main points of the discussion and then form their recommendations. And it was easy to record the discussion and then post this for other groups to review. We did have students attend the session from overseas in different time zones. Students and facilitators also engaged well with the discussion board and follow-up exercise. So overall, it was a really enthusiastic response from everyone. This delivery method overcomes the usual challenges of timetabling, room, and to an extent student availability as well. So we will definitely be rolling this out as a method of delivery in IPE going forwards, something that we would probably not have considered as a desirable option before COVID-19. So thank you very much for your time, and I look forward to answering any questions later.
The Netherlands is preparing itself for the second wave of COVID-19. What have we learned from wave 1 in terms of interprofessional education, interprofessional collaboration, and shared leadership? My name is Wien de Vos, Professor in Education and Training at the Amsterdam University Medical Center, a two-location tertiary care center, 17,000 employees in an IPE program for 3,000 students of 5 care professional programs, together with the University of Applied Sciences in Amsterdam. Let me take you to the context of the ICU at one of the locations of the hospital. In COVID wave number 1, the number of ICU beds increased from 27 to 47. That's about 70%. That means 20 more patients, 20 more beds and ventilators, many more infusion pumps, and the most difficult of all, 70% more personnel, especially ICU nurses. We managed the hardware demand, but had great difficulties with the required nursing staff. Untrained doctors formed teams with experienced ICU nurses, particularly for one procedure, and that was turning ventilated ICU patients into prone position, so-called turning teams. Prone positioning improves the oxygenation, but is a risky procedure in terms of airway patency and management, hemodynamic instability, and loss of intervascular lines. Moving the patient twice a day into prone position and back, 4 turning procedures per patient per 24 hours, is a labor-intensive procedure requiring coordinated efforts among a team of 5. One team member ensures the stability of the endotracheal tube, one protects the vascular access lines, and at least 2 other staff members turn the patient. An experienced clinician who can re-intubate the patient, if necessary, should also be present. Since turning the patient requires experience as well as skills, it was decided that the responsibility for the coordination of the procedure should be with the ICU nurse. He or she had the leadership over the team of experienced doctors. Because this was interprofessional collaboration and shared leadership in optima forma. Now, shared leadership is easier said than done and often used loosely. But the responsibility is depending on the clinical context, the time frame, it should have a beginning and an end, and don't forget the burden of the responsibility. In that respect, turning patient is a relatively isolated intervention in a complex treatment system, short in time with high risks. Now, post hoc evaluation showed great dissatisfaction with the outcome of this leadership. Either the leadership of the nurse was not granted by the unexperienced doctors. These doctors still felt that they were a different breed and higher on the hierarchy ladder. Or there was ambiguity about the roles. What does that leadership mean? Just coordination, or also decision-making, taking responsibility, and taking the role of an educator. Or the leadership was not exercised because the nurses were reluctant to take a high responsibility in just a short occasion. They might be uneducated for that role or felt the hierarchy mentioned before. When COVID wave 2 will arrive, the interprofessional teams will be abandoned. The new teams will consist of not ICU experienced nurses under the supervision of an ICU nurse, and the ICU nurse will receive training in advance: situational awareness, decision-making, team functioning, clinical leadership, and educational leadership. We learned 5 lessons. No interprofessional collaboration in ad hoc procedures. Don't try this at home. Nurses have a great personal leadership, but team leadership might be alien to them and requires training. The context of shared leadership should be carefully chosen and roles defined. Professional culture is relatively strong and might still interfere with all good intentions. And finally, last but not least, no interprofessional collaboration without interprofessional education. That training is not so much about procedures as well as about professional boundaries, boundary crossing, value, and conflict resolution. Thank you for your attention.
Hello colleagues, my name is Rosemary Mackenzie. I'm from the Melbourne School of Population and Global Health at the University of Melbourne in Victoria, Australia. It's a real pleasure to be with you today, and I wanted to share with you one of our responses as educators to support the health workforce in Victoria during COVID-19, taking an interprofessional health lens. One of the immediate impacts that we observed as educators was the urgent need for evidence-based information for frontline health workers. Our faculty saw it as a responsibility to support the health workforce during these incredibly challenging times, and actually came up with a suite of evidence-based online short courses. They focused on topics like resilience, critical care nursing, ethics in the time of COVID-19, and the course I'm going to talk to you about, which was called Communicating COVID-19. Why communicating COVID-19? We were conscious that there was a rapidly evolving knowledge base around COVID-19, not necessarily readily accessible or curated for the needs of the health workforce. Frontline workers in a range of sectors, from acute care to social and community care to paramedics to disability support, were fielding questions from their patients and clients, from their colleagues and from the public, and they often felt quite unable to answer those questions in simple layperson's language. So we were responding to an urgent need for credible, accurate knowledge in plain language that professionals in a range of health and community care areas could be empowered with to answer questions accurately and credibly. The short course was built from the beginning from an interprofessional base. The creators, the target market and the editorial panel were all interdisciplinary and interprofessional. Our production team consisted of a nurse, a young ED physician and an epidemiologist. The important characteristic that they shared was that they were all public health researchers as well. We had an interdisciplinary and interprofessional editorial panel that I chaired. I'm a public health professional with a background in sociology and evaluation, but we also had medical physicians, we had nurses, we had general practice represented, and we had epidemiology and virology represented on that editorial panel. Our approach to the course was built on 4 pillars of interprofessional knowledge: epidemiology, science, clinical care, and a final category of ethics, law, and society. We used as a cue for each of the 8 modules that we built a structure of heralding questions from frontline workers that reflected the sorts of questions that health workers were receiving. Questions like, I have a fever and a runny nose. Should I get tested? I have tested positive. Should I go straight to hospital? Will there be a vaccine soon? When will this lockdown end? What does flattening the curve mean? So these questions were then used as a basis to build knowledge in epidemiology, science, clinical care, and ethics, law and society. We used scores of experts working in the field to answer those questions, and they answered them using an evidence base of carefully researched and curated knowledge put together by our research and production team. We also videotaped those experts, so there was a sense of them speaking directly to the health worker as they took the course. At the conclusion of 8 weeks of staged release of the modules, we had around 2,500 learners, most of them within Australia, but also a smattering from around the world, and a very pleasing uptake from India. The course is still available and numbers are still slowly growing in enrolments. We do realise that there will be a sunset clause at some stage, or the need for rapid redevelopment of some of the modules as our knowledge about COVID-19 continues to grow. If you're interested in learning more about our short course, Communicating COVID-19, or you'd like to share it with colleagues, if you click on the link in my slides, that will take you to our University of Melbourne page with a lot more information and even the opportunity to enrol. Thank you very much. I look forward to your questions.
Hi, my name is Dr. Emily Audette and I'm a middle grade doctor. I'm going to do something slightly different and talk to you about my experience of how the coronavirus pandemic impacted the interprofessional dynamics in a clinical setting, whilst working on a hospital ward looking after terminally ill patients during the peak of the pandemic. Upon reflection, I have an overwhelming sense that interprofessional working was harder and more complex during this time, and I want to explore with you why I feel this was the case. I will then touch on the more positive impacts by looking at how we began to overcome some of the challenges. With a reduction in healthcare staff, the need to minimise movement between departments, and certain professional roles having higher infection risk skills, there was less access to key members of the MDT, including speech and language therapists, nurse specialists, dietitians, and consultants. And at times, this impacted and slowed decision-making. It also led to a loss of a tight-knit support network, both for the patient, but also actually for the healthcare professionals working on the ward. For me, breaking bad news was a particularly different and difficult scenario. It was now often being led by more junior doctors without the support of the patient's own cancer specialist consultant, their cancer nurse specialist, a palliative care nurse, and most importantly, without their family present. Following these conversations, we would then have to call families and break the news all over again. And there were weeks where not being able to share these burdens with the team took its emotional toll. We were then isolated further. Physically, we were told by management to socially distance by segregating from other staff on the ward. Pharmacists used an empty bay to work, and doctors were told to have their morning patient discussions in the staff room, away from the nursing station and the therapists, thus completely breaking down the initial opportunity for the MDT to liaise together as a group at the start of the day. Off the ward, the more formal IPE events at the hospital, such as the weekly grand rounds, were mostly cancelled, causing further segregation. However, I think that the most detrimental issues was the dissemination of COVID information being professionally siloed. Different professional groups were receiving different updates and guidance at different times, causing a widespread feeling of uncertainty and generating an environment of conflict between professional groups for a number of reasons. Professional groups had varying understandings of the viral spread and also of the reliability of the COVID test results, leading to conflicting concepts of risk, conflicting behaviours, and thus conflicting clinical decisions. This ultimately led to a breakdown of trust and high tension as professionals on the ward challenged other professions with regards to safe practice, hugely impacting team dynamics. So what helped overcome some of these challenges? First of all, friendship and peer support. Everyone on the ward had a time where they struggled with a bizarre situation. During this time, I made very close friends with some of the nursing staff, occupational therapists, and pharmacists. I found that colleagues were much more likely to check in on how others were coping. At times, there was a strong sense of unity. And whilst patients didn't have their families present to support them, there were certain moments where there was a strong feeling of the need to stand together with other professionals to advocate for our patients in order to provide the best patient-centred care possible at such a vulnerable time. Healthcare professionals who were unable to come to the ward during the pandemic sometimes gave advice remotely, with the expectation that the ward staff would action the advice. Through this, I learned actually much more about the decisions that other professionals make and gained much more of an understanding behind those decisions through the opportunity for discussions, which otherwise would not necessarily have happened if those professionals had come directly to the ward and directly to the patient. Written information for guidance from other specialists also became more essential, and various resources have become very valuable tools. We learned to resolve interprofessional conflict by acknowledging differences in understanding and escalating to our infection prevention and control team for clear, unified direction. We discussed how we could best facilitate patients and doctors with breaking bad news, and managed to find a suitable space in the outpatient unit for socially distanced meetings where there was more flexibility for the attendance of the patient's consultant or nurse specialist to join the patient along with a family member. Whilst for those who are bedbound, we managed to obtain 2 iPads for the ward so that family members could join remotely. Once I knew that we would be getting the iPads, I discussed with all the team members how other healthcare professionals could use the resource. And thoughts included the occupational therapist could do remote home visits. We could get a translation app to help with language barriers, and an app to help communication with hearing impaired patients who are struggling with lip reading whilst masks were being worn by staff. Ultimately, this pandemic has forced the opportunity to problem solve and think outside the box in a way that I have not seen happen in the NHS before. It's inspired working together to find new ways of doing things in order to continue to provide the best care possible for our patients.
Thank you very much. I think you'll agree that's a really inspiring and thought-provoking series of presentations. And without further ado, I will pass over to my colleagues Alison and Janet, who will lead the panel discussion. Thank you.
Thank you, Sharon, and thank you, everyone. It's a pleasure to work with my colleague Janet for the facilitated Q&A session. We thank the keynote presenter, and we're also thankful to the panellists who you can see on the screen. So we welcome the attendees to write any questions in the Q&A panel. Please feel very safe to do so. So we'll give you a moment to gather your thoughts on that curation of excellent impacts of COVID on interprofessional education and interprofessional practice. So we will just be keeping an eye on the Q&A. Of course, you're welcome to place those into the chat if you're more comfortable with that as a mechanism, and Janet and I will look across both. We do have approximately 15 to 20 minutes for a facilitated discussion. This can constitute specific questions targeted for particular panellists, or general questions or thoughts that you might have, even those of a philosophical nature that might be generating more broad discussion. So Janet, I'll pass to you for a moment if there's any questions in the Q&A, or if you'd like to kick us off in the meantime.
Right, thank you, Alison. So I think probably the audience needs some time to type the questions. Maybe I can ask the first question. So this is my question to Professor Gilbert. So thank you so much for the wonderful talk, and I can see you're so caring about the students during the emergency remote period, emergency remote teaching period. Well, we have more time in reflecting how we can actually do better in teaching at a virtual platform. Do you have any advice to us how we can, as a teacher, to keep a good relationship between teachers and students using the virtual platform? So as we know, university is not only the place for teaching and learning, but also a place for like socializing and establishing relationship. So I would like to hear if you have any idea about the how to keep the relationship with students.
Neil, would you like to reflect on any?
I was just going to offer and say, would you like me to respond to that? Look, with our course coordinator, Dr. Nominandum, he coordinates Health 1000, where, as we said, we have approximately 1,500 students. And even pre-COVID, this is a blended course. So Norman is only exposed to the students in an online environment, yet all the students know who he is because he goes out of his way to have a strong online presence, touching in where he has videos of himself there for the students, pictures of himself with announcements, and successful enough that some of the students did a video at the end where they actually had a picture of him on an iPad in front of them when they were talking about Health 1000, which I think beautifully illustrated the impact he made. So I think, Janet, it's about having that online presence. And I think, as was touched on earlier as well, it's about still creating opportunities for the student to check in. So John mentioned the fact that we would normally have open office hours. Well, do that in an online environment. And again, Norman has created those opportunities where students can reach out, albeit through Zoom, but know that they'll be talking to him directly, not via email.
Thank you, Neil.
Thank you, Neil.
And how about other speakers? Do you have any thought about keeping the relationship with students?
Janet, Rosemary here. I actually think that use of discussion boards that at synchronously and asynchronously, so giving students an opportunity to chat directly with you online, but also answering questions on discussion boards is another technique for staying engaged. And I think the other thing that's important is giving students an opportunity to engage with each other, with their peers. That's the other part of the relationship that's been threatened by our sudden shift to wholly online learning. And that's where I think blogs and breakout rooms can really help to give students an opportunity to talk to each other between themselves and make links that they perhaps follow up outside the formal learning hours as well. Thank you.
Yeah, thank you. I can see a question here from the audience. So this is a very general question. Does the panel think that COVID-19 pandemic actually create an opportunity to increase IPE or IPC? Do you have any thought? Anyone you would like to?
Yep, go Ren.
Yes, I think it opened many opportunities. We haven't used the electronic way of communicating with students that often. And it also gives us the opportunity to do it time and location independent and more in an let's say in a mixed environment. And one way I've learned about IPE is that it should use several sources, and COVID-19 has exposed us in a very quickly and emergency way to these new devices. And as we have learned from all these experiences presented today, is that they often serve good feedback, but also positive responses. So these new electronic ways of communicating with patients are, I think, here to stay and should be embraced and developed further.
Can I?
Oh, I was going to say, can I add something to that? Because I think that it's really interesting when I first when the pandemic first started, and our students were volunteering in hospitals, and there were lots of different roles that people were playing. People were working outside their usual roles. I thought that the potential for expanding IPE and evidencing the fact that interprofessional collaboration was really important was huge, that we would have students who've actually seen it firsthand and the need for it. But I think it's important to think about what Emily was saying about how when people were under pressure, to some extent, the professional boundaries reinforced themselves, and the doctors were taking their breaks in one room and the nurses in another, and so on. So I think the potential is huge, but I think we've got to be aware that it's not an automatic thing, and I think it will depend very much on how we make use of the potential as educators.
Can I just say, so taking that forwards as well, I think that the pandemic has forced both sort of within the educational sector and the healthcare sector a lot of rapid change and doing things differently. You know, many things that we've talked about in the world of healthcare and education, which is about trying to use technology better, it has forced that rapid change and forced people to take that up quickly. I think one of the things that we need to look at is how the how these changes are going to continue to happen, what changes are going to continue to stay, how are we going to be working differently, and then once we've thought about that, look at then when we go back to educating the students, what we need to change in terms of the education side of things to prepare students for that. Working remotely takes a very different skill set to working interpersonally. I think going back to what Professor Gilbert said, there's lots that students can learn by just looking up information, and I think educators need to learn how to sort of facilitate the way that they work. I think that also includes looking at the basics of teamwork, conflict resolution, how to overcome those sort of dynamics, rather than sort of factual content. We might be moving more from sort of just learning about roles to actually learning about how sort of interactions and teamwork and collaboration, to try and prepare people for these sorts of times.
Thank you for those perspectives. Janet, I've just seen that there's a question in the Q&A box from Marique about, for all panellists, did you find differences in outcomes for students and teachers, for example, satisfaction on any post surveys between synchronous and asynchronous undergraduate IPE? So perhaps Neil, Christine, just thinking for your programs so far.
Can you come back and ask me that in about 6 or 7 months' time when we've collected the data, and I'll have a great answer for you.
I'm sure it will all be flying colours, positive. Thank you, Neil. Christine, anything from your perspective?
Yeah, I share Neil's sentiment there in terms of we are waiting for more data, but we were actually, this was a one-off event that we did. We collected feedback from the students both during the chat, during or after the event on the webinar. We also conducted the post event task where they were putting their thoughts and discussions on the discussion board. And actually, engagement in both of those was really positive. Now, I realised that we had a volunteer cohort of students. They were very enthusiastic to start off with, but they were also very keen to point out the positives of this change in delivery of IPE. So I think I said before that in terms of enabling some students to come into a discussion using the chat function, some of the quieter students found that very enabling and different from their experience from face-to-face. And we found that the engagement in the discussion board was also very enthusiastic, both from the students and from the facilitators as well. So a short snapshot in terms of the evaluation is really positive. Again, as Neil says, we'll be rolling this out and doing some longer term evaluation with students who are not just volunteers as well. So yes, it's watch this space, I think.
Yes. And thank you to Marique for the question, and thanks Neil and Christine for your perspectives. Janet, have you got thoughts for the next question? Or any from the panellists yourself or others? Any? Yeah, Neil.
Sorry, I don't want to monopolise, but just pick up on something that Emily said, which I think really is key moving forward. If you think for a lot of large institutions, one of the challenges has always been about timetabling so that you can get people together. Well, we've blown that out of the water now because we get the students together. We don't need the physical space. So it really does give us opportunity to rethink about how we deliver the skills, you know, the opportunity for the students to develop the skills that they need in that online environment where if we can't physically get them together. But also with the caveat to make sure that they're still then able to do that within a face-to-face working environment. So I think, you know, there are great opportunities there that we've learned from this. And I think some of the old barriers will not necessarily be barriers as we move forward.
Can I just come sort of on the back of that, Neil? I think that there is lots of opportunity using technology. I think one of my concerns about the impact of this pandemic is that it is already a huge step to go from being a student to working clinical practice on sort of, you know, in a face-to-face environment, in a hospital environment. And I worry that with the pandemic, there's going to be less and less opportunity for students to go into that environment and actually work hands-on with other professionals and have that sort of much more interpersonal, patient sort of centered dynamic. And I worry that I think that there's lots of potential and opportunity for remote learning, but I think that coming together actually in a patient environment is key to preparing students for their stepping into the world of work. And I think that's going to be a real challenge to work out how you can sort of provide those opportunities safely and appropriately with the right supervision during times like this.
I completely agree, Emily. Completely agree. It's getting that balance there.
Yeah.
Yes, I agree too, Emily, and I know how challenging it has been for our health students across a range of professions at the University of Melbourne to actually get that time in clinical placements and in the work setting during the pandemic, as many healthcare agencies actually shut down their clinical placement programs in Australia to protect the capacity of the workforce to respond to COVID, to keep students safe and so on. And so I think that is a huge challenge for those of us who educate young health professionals going forward, is how do we ensure that they do get adequate preparation in the workplace whilst they're doing so much learning online.
I was puzzling about one question, and that is all the adaptations of the regular program towards this emergency situation. Would there be substantial differences for the IPE teaching and learning as compared to the mono-professional environment? So what are the specific IPE elements which are different in this emergency teaching situation as compared to the mono-professional environment? I can think of some, but I would like to hear your opinion about this.
Perhaps, Reen, if you'd provide one or two of the ones that you're thinking about to help.
Well, I was thinking about one element which is quite different from the monoprofessional environment, and that I would consider connectiveness. All these students come from different programs, are in an alien situation where you speak to each other from a distance behind a laptop. And so the connectiveness between students, as well as between the teaching staff, is a specific element for IPE teaching, which requires specific attention. The other thing, in an emergency situation, the teaching program has to be changed. And for a monoprofessional environment, you quickly find the teachers who should do that. But for an interprofessional environment, you need an interprofessional teaching team, and maybe it takes more time and effort to get these people get together, formulate goals, and get them to work to a program. How are these experiences in Australia, for instance?
Neil, I'll let you take that one.
Oh, thanks, Rosemary. I think in seeing some of my colleagues in teaching into their own uni disciplinary programs, and from experience of doing some tutor training for some of our colleagues within Health 1000, the challenges have been very similar around getting people comfortable with facilitating a group where you can't see the whole classroom when you go into breakout rooms. And so I think some of the challenges that arise there are that when you're face-to-face, you're able to see if there's a problem arising within a group that as a facilitator, you've got to mediate in some way or moderate. Whereas I think when you're in the breakout rooms, you only find that out if you happen to be in that breakout room when it happens. I think the other thing we found as well, and this unfortunately applies for both, is the challenge around when you're running an online tutorial. Not only are you making sure the breakout rooms are working, not only are you making sure Zoom is working for everybody, not only are you making sure that you're sharing your screen appropriately, you've got a whole bunch of different things going on that when you're at the front of the class, it's much easier to manage. And in fact, your levels of multitasking go up quite markedly. I think one of the issues that perhaps does come in is with some of our later students, Alison, particularly where we've got some of the simulation that goes on with the interprofessional challenges, where then we've got to have a set number of students to get that activity happening from the different disciplines. And the challenge there comes up with the social distancing and the touching that might be involved between the students and the mannequins that are being used in the simulation.
Thank you, Neil, and thanks, Ryan, for raising the question. We do have a final question in the Q&A that we will have as our final thought from Agneta. Thanks, Agneta, for the question. And it's something that Emily mentioned around the professional isolation within the clinical setting with the physical distancing on the wards. Any thoughts from the panellists about how we can counteract that in our educational program, so as part of IPE, to help strengthen the IP collaboration? It's quite a big question for a final. Emily?
And sort of, not as an IP educator, but sort of thinking about how things could have been done better and how things could be improved. I think that almost improving education around leading interprofessional teams, sort of leadership in IPE, how you can improve sort of organisation and communication between different interprofessional groups as a leader, because that's quite a different challenge. A lot of sort of, I think still there is very much the escalation up the hierarchy, and so, you know, if I have an issue, I am told to go up to the more senior doctor. If the staff nurse has an issue, they are told to go up to the more senior nurse. But actually, I think we need to probably start to be changing the way that we're working, and on the ground, sort of, and actually, rather than sort of going up our silos, I think, you know, be working together as a team and having a team leader who's overseeing all the different sort of, or able to interact and pull together all the different professional groups on the ward or in that environment. So maybe perhaps some focused learning and sort of focusing on some skills to improve leadership, and leading and working with other sort of professions might help facilitate some improvement.
Great, thank you, Emily. And on that future focus note, where there's something for all of us to think about in our IPE curricula, we'll hand over now to Sharon. Our 20 minutes has now come to an end for our discussion. So thanks, Sharon, for wrapping up our session. We'll just need to unmute you, Sharon.
So thank you, Alison and Janet, everyone, for a really thought-provoking discussion. We're moving towards the end of the webinar now, but before I close the session, I'd like to say a very brief word about the IPE Special Interest Group that several of us are involved with. We're quite a new group. I think this is our third year of contributing to the annual conference. We've recently formulated our strategic goals for the next few years. We want to focus particularly on the student experience, on developing scholarship in IPE, and on building our capacity and expertise to support IPE. If you would like to get involved in the group, could I have the next slide, please? There are several ways you can get involved in the group. You can join our mailing list, and to do that, contact Taslima Begum on the email address that's there. You can view our presentations and resources on the U21 website. If you're interested in joining the group more actively, in terms of joining with a project or with any of our other activities, please contact either me or Alison or any of our core team to register your interest, and we'd be delighted to hear from you. So I hope very much that you will follow up one of those opportunities, and look forward to hearing from you. So now I think all that remains is for me to thank our keynote speaker, Professor Gilbert, to thank all our panellists for their presentations and their expertise and contribution, and my colleagues Alison and Janet, and everyone who's attended today, for all your contributions and interest, for what I think, certainly for me, and I hope for everyone else, has been a really enjoyable and thought-provoking discussion. I'd particularly like to thank our organisers, Corinna Greenwood and Taslima Begum, who you won't have seen, but who've worked tirelessly in the background, both before and during the session, to make the webinar a success. Thank you so much both. So if you'd like to follow up any aspect of this webinar, there will be a recording available on the U21 Health Sciences group after this session. So thank you very much and enjoy the rest of your day. Thank you.
And thank you, Sharon, for your leadership and making this all happen. Thanks, everyone.
Yeah, thank you. Thank you so much, everyone. Bye. Bye.
Thanks, everyone. Bye.
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 Take care.
Bye.